and lead to clinical events which are disseminated in space and time. Or, but if you have the first episode, and you have an MRI that has lesion that is contact enhancing as well as previous lesion that also
an
counts.
asymptomatic
Yeah,
contact
yeah,
lesion.
yeah.
Correct. And then in the previous criteria, so that's right. So you have the concept of dissemination in space, which means there are two lesions in space. So I just imagine it as one optic neuritis, one weak. So space, it's spaced out in terms of the location. So that's dissemination of space. And dissemination this time is, as it explains, one now and one sometime back. Okay, but when you talk about dissemination in time, sometimes you can't have it like, oh, I was dizzy for a few hours and that's the patient's previous symptom. That's unlikely. But the patient had clear diplopia or clearly optic neuritis now with evidence of optic atrophy, and you can call it dissemination in time. So you're right, these were the four regions. The regions haven't changed. So what they did include, however, is that in addition to juxtacortical also can include cortical regions now to make the diagnosis. So it is juxtacortical plus cortical lesions. Okay. Now, previously they would say symptomatic lesions could not be counted towards the lesion count was one of the criteria. But now, if it's asymptomatic or symptomatic, it doesn't matter. It's still counted into the lesion. Okay. And to attack simultaneous lesions, so cortical or juxtacortical, infradental spinal cord, and periventricular, that stays the same. One other additional factor is something that we are always used to doing. So in a patient who comes in with a clinically isolated syndrome, if they have just one lesion on the brain that fits the criteria, then you can do oligoclonal bands in the CSF, which can then count as a substitute for a clinical event or an MRI lesion. In other words, it's talking about inflammation. So that wasn't a formal diagnostic criteria for somebody with CIS to make a diagnosis of clinically definite MS. That's the one thing that you can do. So you can use oligoclonal bands in the CSF. So CIS plus oligoclonal bands in the CSF, you can make a diagnosis of MS now. So basically, it's the tendency is to push an earlier frame for treatment because you know that the sooner you treat, the more benefit you get. So that's what I want to include today is to say that cortical lesions are included, symptomatic lesions are included in the diagnosis, and oligoclonal bands are included in the diagnosis. What is still not included is you had asked me a question a while ago about optic nerve. So optic nerve still is not included to make that. So it doesn't. So optic nerve is a separate one. It doesn't fall into this. So there is no optic nerve. So if they have just an optic nerve lesion, optic neuritis, and then they have oligonucleosis bands, you would still call it a clinically isolated syndrome if they don't have any other lesions on the brain. Okay. I want to touch upon this before we go on to the actual topic of discussion today, which I wanted to talk about was pregnancy in MS. Primary progressive MS, again, unchanged. It has to be 1 year of progression, 2 of 3, either more than one T2 lesion in the brain. They have to have 2 T2 lesions in the spinal cord and CSF oligoclonal bands. So you should have 2 of these 3. So they have 2 lesions on the spinal cord and oligoclonal bands and 1 year of progressive symptoms. That makes a diagnosis of primary progressive MS. Or if they have one brain lesion and oligoclonal bands and progressive symptoms, that makes a diagnosis of primary progressive. It could be any combination of those 3. Okay. So the only additional factor is that symptomatic lesion and cortical lesion have been included again for making the diagnosis. Previously, if they had a symptomatic spinal cord lesion, that would be excluded. And they said, now, that didn't make sense. We don't quite know why that was included that way. But right now, symptomatic lesion. So if they have 2 lesions, one, say, with the cervical spinal cord on the left side, and they have left-sided spasticity weakness that they come in with, and they have an asymptomatic somewhere down in the thoracic cord, progressive ambulatory dysfunction, that's enough for you to make the diagnosis as long as they have one other brain lesion or oligoclonal bands in the CSF. And they've been having progressive symptoms for 12 months. Okay.
So can I ask a question? We had a patient last week, actually 2 days ago. She's like young and she comes in with numb legs, and she had numb legs 3 years ago when she was pregnant. That's fine. We thought she was MS because she was hyperreflexive. Her MRI showed 20 enhancing lesions. So I don't know if that's the same, and how would you classify? Is that
probably has highly active.
Highly
Yeah.
active, and I think
Multiple
that should be
sclerosis.
treated different to other relapses, like, and I know this is not your topic, but I've been meaning to ask you this. Shouldn't we have treated her differently than just steroids? Like,
Did you put her on a tapering dose of steroids?
Mhm.
Going home?
no-
Yeah.
Did we?
I do.
Okay,
Okay.
I actually, this is the reason I think I sent.
Yeah.
you.
I know, but
That,
I
she
had a
was
very
like
busy clinic
very-
Monday.
No, she was very like adamant. She had to go for.
Yeah, her child
She
turned one the
wanted
next
to-
day. She got 3 days of
her doctor
steroids.
said that because she had like doctors that
Yeah.
she wanted.
but I read in continuing that people who are that bad on the MRI should start in
Disease
hospital,
modifying
yeah,
treatment.
and they should start something like cytarabine. I mean, the continuum is really very aggressive about. treating
Correct. I would
MS.
probably get her back to see me in clinic in 2 weeks and start her
Yeah.
on something as
Mhm,
like,
as
so
soon as
highly
possible.
effective would be either Tysabri
Yeah.
or maybe ocrelizumab or
Mhm.
Gilenya, one of the two. If she's got multiple enhancing, I would probably attack her with
Like
Tysabri.
Brain, spine,
Tysabri is the one
spine,
that we
spine.
have. Yeah, so she's young. We have a lot to lose if we don't treat her actively. Yeah, I would put her on the tapering dose of steroids, but have her come back to see me in clinic in 2 weeks
Yeah,
and get her started on Tysabri right away.
yeah.
Did we send a JC index with her to get
No, she
JC
sort of
index?
was leaning against medical advice and saying she'd follow up at a different hospital. So she's,
It does not really matter against medical advice because that
No, we just
kind of
tried
need
that.
to be.
Yeah, we dealt with that.
Just
Got 3 days of steroids.
Okay. All right. We'll get to the questions maybe at the end of the talk. I did want to talk about, so my main topic of today's talk was one is to introduce, of course, the new criteria to understand that there are some other factors that are included, but mainly I want to talk about pregnancy and multiple sclerosis because this is something that you will encounter if you have a patient with multiple sclerosis. MS is a disease of young women, reproductive age group. So, you will always want to know how to counsel them about whether to get pregnant, whether not to, and what to do. Okay. So most women present during their childbearing years. So concerns always are, are they able to get pregnant? Effect of MS on pregnancy, risks of MS in future children. Obviously, they would want to know that. Effects of pregnancy on the course of the multiple sclerosis itself, whether a woman with MS can nurse, and then disease modifying treatment and its implications for pregnancy. So it's an important part of the counseling and the treatment planning for any woman, even for this lady who is coming. You want to make sure that her disease is under control before she plans a pregnancy, if that's something that treatment tends to do. So in terms of effects of MS on pregnancy, MS really does not affect their fertility rate in any way, and epidural anesthesia also does not affect pregnancy outcomes. It is not associated with increased pregnancy or neonatal complications either. So really there is no fear of the MS affecting the pregnancy or the outcome of the baby in any way. Okay. Maternal multiple sclerosis and use of DMT are typically not associated with adverse pregnancy outcomes except for one medication. Which one? Teriflunomide. That's a category X, and that's the one that gets excreted in the semen. So that's the one that has to be watched out for. So men who are treated with disease-modifying agents, if they're on teriflunomide or Obagio, that's the one where you have to, strictly advise for contraception so that they don't, excrete it and that doesn't go with the zygote. So that's a category X in pregnancy. Although the registry now they're looking at it, it's not that bad, but still, when you're advising patient as per the FDA regulations, that's the one medication that you will have to counsel a male patient who's on Obagio, and which we often use for male patients too. What about risk of MS in children and siblings? What is the general risk of MS in the population? What's the general prevalence of MS in the population? Does it say there? It doesn't say there. It's talking only about male and female for patients with MS and parents with MS.
Is it 0.1%?
It's 0.1%. So it's 1 in 1,000. Okay. So with one parent with multiple sclerosis, it's about 2.1%. So it's 2% of the kids. So the risk is much higher. 2 out of 100 do have that risk. And then if it's a daughter, then it's about 3.5%. Interestingly, I was looking at this ratio, and this is again from this paper from 2000. If there are two parents with multiple sclerosis, then the chance of the son having it is 32% and daughter is 30%, which you would thought might flip around that the females would have a higher risk. But if there are two parents with MS, but the risk you can see from 2% it goes up to 30%. Overall, it's about 30% chance if two parents have multiple sclerosis, as opposed to 2 to 3% if it's a single parent who has multiple sclerosis. For the most part, just I haven't seen both partners have multiple sclerosis. Most of the time, it's a single. So the number you'd want to remember is about 2 to 3% risk that the child chances that the child has multiple sclerosis. What about the vitamin D status? So that is more from a recent paper. Maternal vitamin D deficiency is associated with a 2 times increased risk of multiple sclerosis in the offspring, in the Finnish cohort that they looked at. And also the Nurses' Health Study looked at people who took either milk intake. Now this was it was not like a randomized control or anything. It just looked at reported data for vitamin D intake or drank 2 to 3 glasses of milk. The risk was lower. So overall, you would want to advocate that anybody who's getting pregnant, in addition to prenatal vitamins, make sure that their vitamin D levels are normal, because lower vitamin D increases the risk of having multiple sclerosis in the child.
That's only for women with already MS.
This was with yes, Nurses' Health Study was mothers. I think no.
For
This was
any,
for
Any
any no. This is with MS. Sorry, this is with MS. Mothers with MS who have children have an increased risk. So if it's 3%, then the risk becomes 6%. Okay, double the risk. What about effect of pregnancy on multiple sclerosis itself? So typically they have a higher risk of relapse within the first trimester and second trimester, much lower in the third trimester, with maximal decrease in the third trimester, but increased risk postpartum. We know that, right? So immune modulation is related because pregnancy is an immune tolerant state, which is what I always explain to the patients. The analyzed relapse rate in the first trimester postpartum is 2 times. So this is postpartum. They're talking about first trimester. So once they give birth, the chance is about 2 times more than what they had prior to them getting pregnant. So you want to get them on medication as soon as they have their child, depending on what they, whether they want to nurse the baby or not. During pregnancy, for the most part, first trimester, second trimester, they can have a chance of relapse, but overall the risk of relapse is much lower. So, from what I've seen, even here and what I've been reading up about as well, overall the risk is really low. What are the things that might increase their risk of relapse in the postpartum period? What was their rate of relapse in the last 1 to 2 years? So it's important, like in epilepsy, you want to get their seizures under control for at least 2 years before they plan pregnancy. You want to get their MS under control. Like this lady who has these enhancing lesions, she's probably not the candidate that I would say, okay, you can go ahead and get pregnant. I would want that disease to be under control, make sure she doesn't have any more enhancing lesions for at least 1 to 2 years before she decides on getting pregnant, because that is what determines the risk of relapse after she delivers. It also depends on how many relapses she has during pregnancy, use of DMT, yes or no, and then if they have a higher EDSS at conception in some studies. Risk of relapse after a second pregnancy is no different from that of a first pregnancy and is unrelated to whether, so if they didn't have a relapse at the first time, it doesn't mean they don't get a relapse at the second time, or if they had a relapse the last time, it doesn't mean that they will get a relapse at this time. So it's really not related to the pregnancy status itself. It depends on the overall control of the disease. Okay. Pregnancy does not adversely affect disability outcomes. So some studies actually show some beneficial effect in delaying disability, but some others say that selection bias. So we don't have great data to say whether disability progresses or not. All we can say is during the pregnancy period, they probably did not progress that much more, but the postpartum period makes up for that risk. So you want to get them back on. What about infertility treatment? What is your sense of the infertility treatment? What does it do to MS? It causes exacerbation. The risk is as high as up to 7-fold. Okay, so I did have a patient, I can pull up her imaging. She came in with new onset symptoms. On imaging, she had multiple lesions, some enhancing. I saw her in Elkins Park, gave her steroids, said she should come back to see me in clinic. She comes back 2 weeks later and she has florid lesions all over. And the first time I didn't pick up on the GnRH and the infertility treatment because she said she wants to get pregnant. I'm like, I don't think you should get pregnant because you have these enhancing lesions. And the second time we were talking about it, and she said, yeah, I've been getting GnRH shots. And that's where I think this provoked her MS. She did not have a history of MS, but that was her first episode and second episode. She ultimately went to Penn, so I don't quite know what happened. with her. So, but what I read is that, once they have this MS, so you want to withdraw those hormonal treatment, they should start getting better. What about nursing? So some benefit for exclusive nursing during the first 2 months postpartum, but the tendency in the MS world is not to continue nursing for more than 2 months, because at that 3 month period, their immune system is going to get back to normal. And then if they have had aggressive disease, the chances are that they will have a relapse. So you would want to try and limit nursing to 2 to 3 months if possible. If they're very high on it, then maybe limit it up to the first 6 months. Benefits may be lower in women with a high pre-pregnancy relapse rate. Relapse prophylaxis, there is some data to say IVIG prophylaxis. So once they deliver, because it's such a high risk of relapse, some data to say you can use IVIG prophylaxis to help prevent the breakthrough disease. One report for monthly pulse steroids. I haven't really used it. Most of my patients, they deliver and I advise them to come back to see me within about 2 weeks, at which time they would have made a decision if they want to nurse or not. And at that point, we make that decision and go ahead with treatment. And most of my patients have been able to get them back on treatment. Today, I have seen a patient within about 6 to 8 weeks postpartum.
So question, Dr. Kavi,
Mhm.
like the continuum said that once a woman who's high risk delivers her baby, she should have IVIG. Do you advise that? Because I saw it, but I don't recall us ever telling someone to do that.
I haven't used it because
Yeah.
again, I try to advise my
Mhm.
high risk patients not to
Just to
get
come on
pregnant. I
medication.
just get them on medication first. But I did have a patient who just got pregnant and she got
Mhm.
pregnant again, which I gave her steroids. So I did not use
Yeah.
IVIG. But I don't think there's a right or wrong approach. All of these are not controlled studies. You could use IVIG and you wouldn't be wrong, and you could use steroids and you wouldn't be wrong to do one or the other. IVIG, I hesitate a little bit because of the fact that it can cause a prothrombotic state, and postpartum is anyway a prothrombotic state. So that's my only concern with using it. So the one person that I did use it for, I used IV steroids for the immediate postpartum period. Okay. All right. So did this line. So DMT, what about DMT and pregnancy? Are there any medications that are FDA approved for use during pregnancy at all?
No, but women do continue on. I think Gilenya, they don't stop.
Not Gilenya.
Not Gilenya,
Glatiramer. So Copaxone or glatiramer acetate is a category B. Okay, so they can continue if they want to, but for the most part, the OBs are not comfortable and they end up stopping the medication. But glatiramer acetate and interferons also have not shown to have any fetal damage or anything. Gilenya is a oral medication, it's fingolimod. So that is not okay for going through pregnancy. So first trimester glatiramer acetate have not shown any increased frequency of abortion or low birth weight or preterm delivery congenital anomaly. So that's relatively safe to use. So also is interferon beta, did not show any differences. Natalizumab in the first trimester did show, third trimester may show neonatal anemia and thrombocytopenia. So natalizumab is Tysabri. So some patients who have aggressive MS who are on natalizumab, there is the pregnancy registry which has been following these patients. Although in the real world, we don't tend to continue, or if I feel the patient is so aggressive, I refer them to PEN. But it is okay to continue it up until the third trimester, after which you might stop for neonatal anemia and thrombocytopenia.
Is that a 6 monthly thing?
No, it's the 1 month.
Oh, the 1 month.
So 300 milligrams once a month. Natalizumab.
Would you switch at that point or just keep them off?
I would probably keep them off and use steroids in between. So steroids are okay in pregnancy. So I would, except for first trimester. So I would probably do natalizumab during the first and second trimester and do steroids during the third trimester to sort of match if I really have somebody who I feel very strongly they need to be on DMT. Okay. Yeah, it's a very complicated topic, but I think that's sometimes you do deal with it, and I try and tide it over with steroids during the course of the time. So with the different DMTs, fingolimod is Gilenya. They did see teratogenicity in animals as well as some amount of human teratogenicity. The recommended washout period is about 2 months. Concern is always a rebound with Gilenya because at that 2 month period you may see a rebound. Dimethyl fumarate or tecfidera They seem to be teratogenic in animals, but not so much in humans. Again, all of these medications have their own pregnancy registries. So a lot of this information, because in the trials, you never use these medications for pregnant women, right? So all the information that we get for the humans is primarily from the registry. Okay, so there might be some amount of bias because not everybody goes on the registry and says, I was on this medication and does that. Although I encourage, sometimes I do sign my patients up myself so that they go on the registry. So with dimethyl fumarate or tecfidera, again, there is no washout and there is no special concern. Teriflunomide or Aubagio did have teratogenicity in animals, and yes, for teratogenicity as well for the leflunomide, which is the parent component that was used in rheumatology. But fortunately for us, if the patient is on Aubagio, the moment they tell me they're pregnant, I could use something to wash it out. Do you know what it is? Cholestyramine. So I give them a course of 11 days of cholestyramine, and I wash it out and I target their level to 0.02. Okay, and hopefully after that they should be good. So the 11 days they will be on the cholestyramine, because otherwise it's a washout period of almost 9 to 10 months. Okay, so it does have a long half-life. Alemtuzumab, I haven't used it, but the washout period is 4 months, and this can cause transient hematological abnormalities because that's the one medication that also causes autoimmune disorders, good pastures, ITP, hypothyroidism. So even in the mother, it can cause a lot of autoimmune diseases and can cause transient hematological abnormalities in the neonate.
Right, this is the 1 year one, right?
This is the 1 yearly one. The first year you give 5 days, the second year you give 3 days, and then you're done.
So
Okay.
a woman can have it for 5 days and get pregnant after 4 months.
After 4 months
Yeah.
for this one. Yes. Yeah. So, but typically I think I haven't used it. Again, I'm concerned about the autoimmunity associated with it. And I try and manage between Tysabri and ocrelizumab for my patients. I haven't really used alemtuzumab for fear of provoking other autoimmune conditions, which is pretty high. The thyroid is almost as high as I think half the patients get it. The ITP is almost as high as 30%. It's really high. I haven't used it. But a 4-month washout period is what is recommended for alemtuzumab. Natalizumab is Tysabri. It's about 2 months. And then, like we said, transient hematological abnormalities in the neonate, especially use it in the Daclizumab is actually off the market since March of 2018. Okay, this was from 2016. That is why this is here. But I didn't have time to black it out. But Daclizumab is off the market. Do you know why it's off the market?
Is this the one with the cardiac toxicity?
No, that's
No.
mitoxantrone.
Okay.
Daclizumab was approved for use only within the last few years, I think 3 years. It's called Zenbrita. And we saw several cases of encephalitis that was associated with daclizumab that AbbVie and which is the other Novartis, I think. It was a combined pharmaceutical company. They voluntarily withdrew it from the market as of March of 2018. So it's no longer used. It's different from PML. No, it was just an encephalitis that was caused. I don't quite know what kind of encephalitis, but it was encephalitis that was caused that they saw and they withdrew it. Again, I haven't used this personally. Both of these are relatively new. This is definitely newer than alemtuzumab. Ocrelizumab, the comfort comes from rituximab, so that's why we end up using ocrelizumab a lot more. Ocrelizumab, again, no teratogenicity in animals or teratogenicity in humans, but it does last for 6 months. We know that on the effect on the immune side. So we try and wait for 6 months before they can plan a pregnancy.
And this is 6 months.
This is the 6 monthly.
Okay.
This is the 6 monthly. This would be 600 milligrams, 6 monthly. This is 300 milligrams monthly.
So Dr. Babu, all of these can be initiated outpatient, ambulatory, except for fingolimod, right?
That's the only one that
That's the only
needs
one that
the
needs
first dose observation.
The
However,
cardiac.
there is a newer one that potentially might be coming out by Biogen. So Biogen makes fingolimod. They also have a new molecule called
Oh, yeah.
siponimod,
Yeah.
which is a Sunrise study that looked at it. And according to that, the bradycardia is not as much and may not need a
Because
it may
when
not
we-
need a first dose observation.
Okay. We had your patient who needed to get ocrelizumab. You remember, like 3 weeks ago, she came in with weak legs. She had to start ocrelizumab.
Yeah, I saw
and
her
she
in clinic
didn't. You
today.
saw her?
I saw
Great.
her in clinic today.
Because Lakshmi was like, she'll have to get admitted for her first dose of ocrelizumab. And I was like, I don't know. I don't think she does. So
No, she goes to the infusion center and she gets
the
it.
cancer center here. Oh, okay. So we weren't sure what to tell the patient.
Yeah, so she decided against Ocrevus because she has is there a malignancy risk with ocrelizumab?
B cell. B cell?
No, not so much. You would think B cell because it's CD20, but no, it's actually blocking the CD20.
Okay.
It's breast malignancy. It's 1 in 100, and she is 32. Her mom had breast cancer at 38. So today we decided, she came to see me in clinic today actually, and we decided to go with Gilenya instead.
So she'll be coming to that.
She'll be coming for the first dose observation. Yes. Yeah, so overall, this is the washout period. So teriflunomide is the only one which says no washout really required. But the others, there's variable periods of time depending on their half-lives. For Gilenya, 2 months. Natalizumab, you don't use, or you don't see it much. For Aubagio, the washout period. And then for natalizumab, 2 months, and ocrelizumab, 6 months. Okay, let's go to questions.
25-year-old woman with recent onset multiple sclerosis comes with her fiance to discuss her management plan and any precautions and adjustments in relation to her family planning following in their marriage in 3 months' time. Her course includes 2 relapses in the last 9 months. The second relapse occurred despite treatment with disease-modifying treatment, which she was fully adherent to. What would you suggest regarding pregnancy and her recent diagnosis of multiple sclerosis? Adopt a child because the risk of postpartum relapse is worse if her MS is too high. To become pregnant as soon as possible, defer pregnancy while trying to achieve control of MS. She is not at risk of long-term disability from the MS by getting pregnant. So defer pregnancy.
Defer pregnancy, and why would you want to do that?
You want to achieve control for 1 to 2 years with that, because not being well controlled will increase the relapse rate afterwards.
Yeah, what tells you that she's not well controlled?
She's had 2 in the past time.
She's had 2, 2 in the past year. So 2 relapses in the year is bad sign. Also, the fact that she did take her DMT and she was fully adherent to it, and despite that, she had the relapse. So that's a bad sign. So I would say yes to defer pregnancy while trying to achieve control. At least a 2-year control is preferable, and inadequate control causes progression, disability much higher post pregnancy.
32-year-old female African-American with history of MS since 2016. She was started on Copaxone after her initial brain MRI showed lesions, and she had presented with right-sided spasticity and bladder urgency.
So those are her lesions. She has something going on here on the left side, and then this is also on the left side. I think this is the new right-sided spasticity and bladder urgency. Oh no, this is the next one. Sorry, yeah.
She was on Copaxone for a year and developed new ataxia and was found to have a new lesion in her brainstem cerebellum. Her DMD was switched to Tecfidera down fumarate.
Fumarate, yeah, it's dimethyl fumarate, yeah.
She was recommended to use definitive form of contraception. She comes to clinic 3 months after. She has just tested positive for pregnancy. What would you recommend?
Uh-oh.
Yeah, second one.
Okay. And what is the medication you would wash out with cholestyramine?
Teriflunomide.
I have another choice.
Their names, all the names are so similar. Tecfidera, teriflunomide, Cladribine, Gilenya. It's like all mixes up.
Yeah.
So teriflunomide. So if the patient was, yeah, that's true. But you can either stick with the generic names
Yeah.
or decide with the brand names. But that's the one that you would use. If it's the teriflunomide or Aubagio, you would use the 4 grams of cholestyramine 3 times a day for 11 days to wash it out. And not leflunomide, teriflunomide levels to less than. And this is what we said. If it's planned pregnancy, you want to stop it a month before. Lateral interferons, again, like I said, though it is okay to continue, most OB people don't like to continue it, and we stop it. Always wash out is for the teriflunomide. Now, the same patient.
Her pregnancy is going well towards the end of her first trimester. However, she develops mostly right leg. She recalls having a prior relapse with right-sided weakness. She also has new bladder urge and incontinence. On examination, right leg is 4 out of 5 as compared to 4 plus.
To 5 out of
To
5.
five.
Yeah. So it's a little bit weaker than before.
DTR is still brisk. No other new findings. What will you do next? Obtain the MRI of the brains. See else.
Like pan MRI.
MRI.
Remember, she's still pregnant. Okay.
Treat with IV steroids, check the urea culture, or obtain urgent OB info and urology consult. Perhaps the fetus is
Causing leg weakness and bladder urge. Who wants to answer it? You can answer some. Or...
I mean, I know the answer.
Wow.
Okay, what do you think? One,
I would
what
do
do
the
you,
MRI.
you do the MRI?
Likely a flare.
It could be a pseudo.
And we
So
don't know
that's
that
first thing
entity.
first. So pregnancy does increase the risk of you having increased urinary tract infections, right? So that possibly explains the bladder urge and incontinence. And she had already had weakness, a little bit of baseline. She recalls having a prior relapse with the right side weakness, and now she's a little bit more weak compared to before. Given the new bladder urge, you would always want to think UTI, right? So you want to get a urine analysis and culture. Don't treat with steroids until you do that. Don't get a pan MRI. The check urine analysis and culture would be the right answer for that. Okay, so now
Her UTI was treated, she received IV fluids and she felt better over that week. In her second trimester, her OB notes that her walk has changed from ataxic gait to seeks urgent unexamined. She has new onset nose ataxia on the right with possible intranuclear ophthalmoplegia.
where are you localizing that to? MLS. Yeah, possibly right MLS, cerebellar peduncle, something like that, right? With the ataxia and the INO. And she's in the second trimester. Now, typically, she should not have had a relapse, but you can get a relapse even during pregnancy. And this is totally new for her. So that would make you sort of alarm bells ringing because this is not something that she's had before. And her OB was right in referring her to the neurologist. So choices are obtain MRI with contrast, obtain MRI without contrast, obtain urine analysis, start on IV steroids, all of the above, but 4 and 1, all of the above, but just 1.
Yeah. Like the
All
bottom.
of the above, but probably, right? You get a urine analysis, but I would want to urgently look at her brain without contrast and then probably start on IV steroids. Again, it's safe to start IV steroids in second trimester. It's not safe in the first, but second, third trimester, we're totally okay to do steroids. Steroids really have no benefit long-term prognostically, but does help hasten recovery to some extent. And that is something that we could use to tide over during this period. She develops hives and edema of her tongue in response to, oh, Joe. Oh, okay.
Sorry, typically to diagnose the lesions in MS, you don't need contrast, or do you need?
You-
contrast is for active lesions. But yeah,
Yeah, so
So
pregnancy,
otherwise you would.
yes, pregnancy gadolinium is a contraindication. I don't know if I would necessarily want to give contrast for everybody. Like this lady who came in, it was important because it's the first diagnosis. Typically, after 2 or 3 times, I don't give them contrast unless I see a new T2 lesion because how else is going to change? If it is a new lesion, I should see it on T2 unless it's hyperacute. And if I do see a new lesion on T2, then I might give them contrast. But there is always the fear of contrast accumulating in the basal ganglia. They see MS patients having multiple MRIs over the last 20 years who they've been following, and they tend to get Parkinsonian signs now, and they think it's because of basal ganglia accumulation of the gadolinium. So the trend is to minimize use of gadolinium if possible. Yes, it's useful for the first few times, maybe 2, 3, 4 scans. After that, I wouldn't do contrast for everybody, and not for pregnancy for sure. But MRI is relatively safe in pregnancy. Right.
she develops hives and edema of her tongue in response to the methylprednisolone for first dose IV. She admits she has never received steroids before. She continues to have the INO and cerebellar ataxia. Her MRI without contrast confirmed right-sided cerebellar peduncle and pontine lesion.
Mhm.
What would you like to do now? Deliver the baby now via C-section, consider DMD, consider Benadryl, Epinephrine, and IV steroids, pure steroids, ACTH, flex. Well, I'm out of options. Tell the patient to wait. I don't know. You can do plasma exchange. Huh?
You do. There are multiple answers
There
here.
are multiple
So
answers.
yeah, it's not a one choice. So you can get to choose. What are the things that you would choose
I mean,
if you were her doctor?
I mean, delivering the baby is an option, but it's a little too extreme. I
Second
don't-
trimester.
Right, so it's too extreme. So I mean, if she is like okay,
How is that going to help her? No,
yeah, okay.
no, don't go for
Right.
that. Okay, let's try again.
But I mean, I
You
would,
have other options to
okay.
try.
I don't want to do BMD when
Okay,
she's
correct.
pregnant. I can do like a Benadryl with like,
Correct, treat her
like
hives
ranitidine
by
and-
giving her some Benadryl and
Right.
things like that, but you can't do IV steroids again because of her
Oh,
response to it. But we just had a patient recently, I don't know who saw my patient who had the same, she wasn't pregnant, but she had the same reaction to methylprednisone. Although you use steroids for treatment of hives, some patients can potentially be allergic to steroids, okay? So IV steroids. You have a
It's
couple
just
other
it's really
options.
useful. I learned.
So what are your choices? What are the ones that you would go for?
I mean, so I can tell her to just kind of no. I don't think I can. Plasma
You
exchange
can
is-
choose more than one. Okay,
Oh, yeah?
plasma exchange
Hmm.
would be one option, or
ACTH is like
ACTH.
I mean, this is the
Yeah, I mean,
typical
it's the
indication for ACTH.
Correct. So this
Yeah.
would be a classic indication for ACTH or PO steroids. Okay. My patient who came here, who got the IV steroid and Solimedrol, and she got hives and edema, we actually put her on PO steroids and she did fairly well. But how much PO steroids would you give her?
60.
Really high dose. So that's what it is. So when you're giving her oral methylprednisone,
Oh,
it's
wow.
1,000 milligrams of oral methylprednisone or Decadron 176 milligram per day. That is 44 4-milligram tablets, okay, or 1250 milligrams of oral prednisone itself,
Wow.
okay. So that's a big dose of oral steroids, but that's what you could use, or you could do plasma exchange and say, that's done with it, and probably that's the way I would go if she's already in hospital and treat. Or you could do ACTH. Now, ACTH is not on formulary here, I believe, is what the pharmacist, because I was trying to get it for my patient who had this reaction. I said, okay, I'll try ACTH for her, because that's one of the indications that we use ACTH for. There are a couple of others, and we can discuss them shortly. But ACTH is IM, ouch. So IM twice a day, more ouch, for 7 days, followed by 4 days, followed by 3 days, once a day. Okay, so 40 twice a day for 7 days, 20 twice a day for 4 days, and then 20 once a day for 3 days. That's the recommended dose. So overall, a period of 2 weeks, IM injection almost every day, twice a day. It's a little painful, but we could potentially use that option for treating. What are some of the other indications that you would use ACTH in preference to steroids for somebody who comes in with a MS exacerbation?
Steroid psychosis.
Steroid psychosis. What else?
So is there like some research that it's more effective than steroids? Or
Not
equal?
really. It's about equi-efficacious, but in patients who have severe diabetes with diabetic ketoacidosis or severe complications and a lot of
Avascular necrosis.
Yeah.
history.
so those kind of things, then I would not give steroids. I would probably prefer ACTH over steroids. Okay, plasma exchange is considered as a second line management according to the guidelines, but for pregnancy we could use it in this case if she doesn't respond to it. Okay, so those are 3 options, and I haven't put in flex here, but flex, PO steroids, and ACTH would be the way to go if she did not, if she had an allergic reaction or she had something else that precluded. Like for instance, same thing, could change the scenario and say she became overtly psychotic overnight, and that's a reason for you to change. Okay. This is not the one. I think that's about it that I wanted from this. So what happened to? Okay, maybe you can read. I'll see if it makes sense. If not, I'll change.
Your patient is a 28-year-old woman with active disease at the time of onset of MS. She's had relapses. She's had relapses in the past year and with partial recovery and new and enhancing MRI lesions. What would be an appropriate treatment strategy to discuss with this patient? Wait until the patient's prognosis is clear. Depends on your JC virus status and family planning considerations. Discuss starting treatment with a highly efficacious therapy. Initiate a trial of interferon beta and letinur something acetate to see if relapses stop.
Lateral acetate is Copaxone and interferon beta. It could be variable Avonex or Betaseron, any of those.
Maybe I'm just guessing maybe the interferon beta long-term treatment.
They
What
haven't
are
told
things
us
that-
what she's had already.
Yeah, but she's coming to you
Primary
Oh, this is
for the
the
first
same
time.
patient?
It's like your patient, but
Yeah.
except that she's having not just lesions. She has enhancing lesions and she's had relapses in the past year with partial recovery. Bad
Little
signs.
aggressive.
Bad signs. You want to start with a highly efficacious therapy, okay? Like for this lady here that came in to see you. You know what? I think my question, I was doing this last night at like midnight. So my questions are probably all over the place. I don't know where my question about nursing went, but resuming, okay, this is where that was a different question. So what advice? So now that you've delivered the baby, okay, she goes through her plex, she goes through third trimester without any issues. Now that you've delivered her baby, what advice do you give the mom about resuming her DMD and nursing? Nurse the baby as long as she pleases. If she has a relapse, you will take care of it with steroids. Nurse the baby for about 2 or 3 months. Consider starting DMD. Do not nurse the baby. Risk of relapse is high. Start the DMD now. Nurse the baby. Put her back on Copaxone. And some DMD is better than no DMD.
But this is the woman who had a,
She was the one who was
she
on
had a new thing
in pregnancy. Yes,
She's a high risk.
she's a high
So
risk.
we would advise against breastfeeding.
Probably, yeah. So I would probably say, if she's able to
Start
nurse
now,
within,
yeah.
and I normally say, I'm gonna go through your approval process because that takes at least not 2 or 3 months. No,
2 or
not
3
that
weeks?
bad. No, about
Yeah.
2 or 3 weeks. So by the time they come to see me postpartum, it's about 2 weeks. They nurse the baby. If they feel strongly about nursing the baby, I say carry on till I actually get the approval for your medication. And then after that, I say stop it, and then we give you the medication. So I'd say do not nurse the baby, or maybe just so one of these two would be. But she's already had a relapse in pregnancy. Not a good sign. She was failing Copaxone. I had started her on Tecfidera, and then she got pregnant on that. So that's where we are. Actually, I have a patient. That's a true story. She, of course, decided to terminate her pregnancy now. So that's different. She's probably going to go back to Tecfidera, but it's a true case. All right. So in summary, pregnancy is safe for women with MS with no increased risk of complications. It does not adversely affect the long-term risk of disability course, although relapses postpartum may increase disability. Relapses postpartum is 2 times the rate prior to pregnancy itself. So relapse rate in the last 1 to 2 years is important and are the strongest predictors. Exclusive nursing in the first 2 months may be associated with decreased risk of postpartum relapse. So maybe for the first 2 months you can, except the 3-month mark that you want to get that DMD back in. Some value for prophylactic IVIG or steroids, pulse steroids. And then DMD management requires consideration of pregnancy for sequencing decisions. And pregnancy should obviously be planned, although almost I've never had anybody who tells me that they plan their pregnancy. They just come and they say, I'm pregnant, and that's it. Drop the ball on me. I'm like, it's your responsibility now. Do what you want to do. I'm pregnant. All right.
Is
So
vitamin D supplementation part of the treatment for all women with MS?
I do it for all my MS. Yeah. I just had a few more questions. Maybe we can go through them. You still have 4 minutes. So let's do this on the McDonald's criteria. Yes, I do give vitamin supplementation for. It depends on what their levels are. So normal doses are 30 to 100. If it's between 20 and 30, I give them about 1,000 units. If it's between 10 and 20, 2,000 units. If it's under 10, then I do the once a week 50,000. The rate of response and the direct relationship. So vitamin D does have an immunomodulatory effect. It does change the balance of your pro-inflammatory versus anti-inflammatory T helper cells, but not so much in African American. So in African American, they tell me that you can go after it, but don't go after it aggressively. So I try and target it about just to meet 30 to 40 and stop. Okay, so
according to 2017 revision of the McDonald criteria for the diagnosis of MS, it is recommended that brain MRI be performed for all patients who are being considered for
This is a very easy one.
diagnosis. Yeah, that's true.
Yeah, but that is one of the recommendations, by the way. You can do the next one too, since it's too simple.
According to the 2017 criteria, in patients with typical
CIS,
clinically isolated syndrome,
optic neuritis, or INO, which is very classic for MS. So
brain MRI can substitute for clinical findings in the determination
dissemination in space, dissemination in time,
time notes. We substitute within
brain MRI. So what do you use the brain MRI for?
for dissemination space.
Why not time? What did someone just tell you a while ago? What is your, I basically wanted to know that you understand the concept of dissemination in space and time.
Oh, so you don't need, oh yeah, that's right. 'cause of the
So this
changes.
is a patient with a clinically isolated syndrome. So they haven't had other symptoms
Yeah, you
before.
haven't had the
For
dissemination in
MS,
time.
you need two different episodes. But can your MRI substitute for dissemination in time? It can.
Yeah, no.
And how do you think it can? Or what should the MRI have to tell you that it's disseminated in time?
Multiple.
You can do multiple MRI, no, multiple
Lesions.
MRIs.
Oh,
Yeah,
oh,
multiple lesions is space, so that's space.
Yeah, yeah.
Okay, so she has the optic neuritis, she has a lesion in the periventricular, she has a lesion in the spinal cord. Boom, she meets criteria for dissemination in space. For dissemination in time, she should have had 2 relapses, but this is just her first presentation. She hasn't had a second relapse. So what else can substitute?
The MRI, second MRI.
Second MRI can, or on this MRI, you give her
Asymptomatic
contrast, asymptomatic contrast enhancing
lesion.
lesion.
Right, right.
So that will substitute for it. So it's both dissemination in space and time. Okay. Where am I?
That's how we make diagnosis for light, right?
Exactly.
Yeah, yeah.
Because she had multiple lesions, some enhanced in areas you wouldn't expect, and some, yeah, she had some.
Okay. The 2017 revision spinal MRI is advisable for what kind of patients? These are very simple questions. For all of them, correct. So A or B or C. Basically, you want to think about spinal MRI. According, again, the recommendations say you don't need to get a spinal MRI. I get it for as a baseline for my patients, because some of them are asymptomatic. But special population, older population, non-white, brain MRI does not fulfill criteria for dissemination in time or space, then you can get a spinal cord MRI. So standard MRI is not effective in distinguishing cortical lesions, but you can get a 7 Tesla MRI and you can look for cortical lesions. Now that cortical is a part of your diagnostic criteria. So it's a 7 Tesla MRI. Okay, this is more like a clinical question. What is your gone?
22-year-old female, first presentation of optic neuritis in the right eye. Exam shows normal neural exam except for red desaturation in the right eye, sees gray, and right APD. Right MRI shows enhancement of the right optic nerve, short segment, single periventricular non-enhancing T2 lesion,
In the
right
corner
corner radiata, 3 millimeters. What's the diagnosis?
Is she a radiologically isolated syndrome? Is she a
No.
clinically isolated syndrome? Is she clinically definite MS? Is she primary progressive MS?
Is it C?
What is your, how do you make a diagnosis of clinically definite MS?
Oh, optic neuritis is a class clinically.
It's just clinical, yeah,
Yeah.
it does not count. So she has how many lesions?
It's just one, so it's
Just one
radiology.
lesion, but we only looked at MRI brain, right? We need more data. So
Yeah.
right now, she's just a CIS.
Mhm.
So optic nerve does not count for lesions. She has one lesion. She needs one more lesion to make that diagnosis, right? We don't know yet. So what do you do next? Obtain MRI brain, CT spine. An MRI C spine shows single lesion at C3, C2 hyperintense and non-enhancing. What's the diagnosis now?
No, it's the clinical diagnosis.
But she still has only one episode clinically. So it's meeting criteria for clinically isolated syndrome, but dissemination time or space?
Just
Just space, because she has one lesion on the brain, one lesion on the card. So space, it's spaced out, space. It does not meet for time because it's her
Right.
first episode. So what can you do next?
oligocorn bands.
Oligocorn bands. There we go. Okay. So we can, this was a question, it's still clinically isolated syndrome, but not dissemination in time. So it's still a CIS, and optic nerve lesion is not considered in lesion count yet. Okay. But there are some discussion to see if you could include it as a symptomatic lesion or not. So what do you do next? Don't treat, wait for 6 months. We already discussed this. Obtain CSF and look for oligoclonal bands. CSF shows oligoclonal bands, 5 in the CSF, none in the serum. What is the diagnosis? It's already shown up here. So it's clinically definite MS now. She has dissemination space because of the periventricular lesion and the spinal cord lesion, and then dissemination time because she has the current optic neuritis and the oligoclonal bands in the CSF. So okay to proceed with DFT. So primarily with this criteria, you can help diagnose earlier and treat earlier. Okay.
Thank you.